My savior, the retention sutures. We had a 48-year-old female who was status post scleral tear repair. She had aphakia, aniridia, vitreous hemorrhage, and a long-standing retinal detachment. Vision was hand movements. 325-gauge sclerotomies were made. Limbal markings were then made at the desired points for retention sutures. Anterior chamber membranectomy was performed using a vitrectomy cutter. Limbal grooves were then created to bury the suture knots. 9-0 proline suture with a straight needle was passed vertically across the anterior chamber from one side and removed from the other side with the assistance of a bore of a 26-gauge needle. The suture was then passed back to the other side at a distance of about 2 mm from the previous exit. Both loose ends were then tied and the knots were buried in the groove. The procedure was repeated in the other half of the anterior chamber vertically as well as in both halves horizontally in the same plane. The end result was a double hash-like configuration of sutures across the anterior chamber. Core vitrectomy was started. Proliferative vitreoretinopathy membranes can be seen due to the long-standing retinal detachment. The proliferative membranes were peeled using a diamond-dusted forceps, and the retinal folds were opened. Subretinal bands were removed from a iatrogenic break. Breaks were marked with endocautery. Inferior nasal retinotomy was created to drain the subretinal fluid. Also, a relaxing retinotomy was created in the inferior retina. Fluid air exchange was performed. Endolaser was given to the peripheral retina and around the areas of breaks and retinotomies. (5,070 strokes of silicone oil was injected to a level just at the plane of the retention sutures. Oil overfill was avoided. The anterior segment photo taken on post-op day 1 showed no silicone oil corneal touch. The retina was on post-operatively, as can be seen in this post-op off-close picture. Vision had improved to finger counting 1 meter. This silicone oil retention sutures saved my day.
Okay. So you made a mesh over that area?
Yes, ma'am. I made a mesh. Patient was having an eye.
For what?
There was no iris. Only one eye of the patient. Otherwise, other eye was blind. This was the eye post-trauma with very poor vision. So I thought I should do something to give some vision, some ambulatory vision, so the patient can live her life. She was 60 years old lady.
So instead of iris, you are using that mesh?
Ma'am,
or
there
you are
was
placing an IOL over that?
long-standing retinal detachment with PVR. It was very difficult to put an aniridia IOL in a patient in whom you have to do a lot of retinal maneuvers. You need a good visualization for do posterior maneuvers also. So if you do put a iris or whatever artificial measure, it will have a small pupillary area, and to that pupillary area, it's difficult to do retinal maneuvers, especially in periphery.
So the purpose of that sutures placed is to place the IOL?
To prevent oil migration in the AC, to prevent corneal degeneration.
But oil will come later, no?
No,
After emulsification.
This mesh will. This I put 5,000 centistrokes. 5,000 centistrokes are the quality, it will not emulsify faster. Patient have now nearly 1.5 years follow-up. He is still maintaining 3 meters vision, coming to OPD walking. 5,000 will not emulsify faster. And if it fast emulsifies, if you cease emulsifying oil, it will usually emulsify, and emulsification bubbles will be more seen earlier in the post retina. It will not collect in the AC so fast. This mesh will act as a what we call the tension impediment to prevent migration of
No,
oil
it's
will make
just
a
a mesh, no? There
Yeah.
are, so
It's an old technique, ma'am. Since 1960, it has been described. It's not a new technique, but not been frequently used because we have NIRIDIA, SFILs for doing the surgeries. But in those cases, we don't have RDs or these complicated posterior segment problems. If in this case I would have implanted an NIRIDIA SFIL, I would have found a lot of difficulty in doing retina surgery.
You left it with me. Yeah. Thank you.
okay, thank you.
Thank you, ma'am.